Thank you so much to the 99 NICU Organising Committee for inviting me here to Lisbon to talk to you all about the long-term outcomes of the PLANET-2 study, which was a randomised controlled trial of platelet transfusion thresholds in preterm babies in NICU. And so to look for engagement from the beginning, the first thing we're going to look at is, what is your current practice? What do you do? So what platelet transfusion threshold do you use in your neonatal unit for a baby that isn't actively bleeding? So these thresholds probably are different from what they may have been 10 or 20 years ago. And we are going to next, thank you, look at regional differences. 5 for term babies. Wow. So we can see that there are still differences. And we can see what's most common, because the biggest numbers on this word cloud are the most common ones. And we're going to revisit this question a couple more times during this presentation. So we know that there are regional differences in platelet transfusion thresholds. Kremer et al. In 2011 published this study, which compared responses to clinical questions about platelet transfusion thresholds in NICUs and neonatologists in Germany, Austria, and Switzerland compared to the US. So in the graphs at the bottom, the darker color is the American neonatologists and the white is the European neonatologists. And we can see even with different clinical questions, we can see that in a baby who was 27 weeks gestation, 950 grams, but stable with no bleeding, we can see that comparing the thresholds used for that baby compared to a baby who was unwell, so with sepsis, on mechanical ventilation and vasopressors, but also with no bleeding, that despite the clinical differences, there still was a substantial difference in the thresholds chosen between the American and the European neonatologists. And we can see that the American neonatologists tended to choose higher platelet transfusion thresholds. The next thing we're going to just look at one slide only, because Alexandra is presenting on behalf of her team next. And we can see practices in platelet transfusion thresholds in Europe. And this was published last year. And we can see that even in the violin plots, we can see that the thresholds are broadest or broader at 25 as a threshold. It is actually broadest in most of them at 50. And we can see that there is variation in practice, but that is all I'm going to talk about Dr. Scriven's presentation. So despite all of the progress in neonatology since 2012, and what many neonatologists say they are trying to prevent with platelet transfusion, which is intraventricular hemorrhage and severe intraventricular hemorrhage and the devastating consequences that can happen as a result of this hemorrhage, they've stayed the same. This data is from the Vermont-Oxford network, published in September 2023. Plenty of studies have shown us before that platelet count is a very poor indicator of bleeding. And despite what we know, platelet transfusions appear to be increasing. Elgendi et al.'s 2021 cross-sectional study included 1.78 million babies over a 17-year period and showed not only that platelet transfusion is associated with increased mortality and morbidities in the form of ROP and severe IVH in the preterm babies that it looked at, but also that it showed that a trend towards increased utilization of platelet transfusions across the study period. We can see that there's sometimes other reasons chosen for platelet transfusion, and Kumar et al. Study, which I'll mention briefly a couple more times, that was published in 2019, randomized babies with a PDA to platelet transfusions along with ibuprofen as a means of treatment to close the PDA. And it spoiler, it didn't demonstrate a change in time to PDA closure. So it is also very important to understand why we do the things that we do and look at historical context for both our practice and for our research. So we don't have a huge amount of evidence for the platelet transfusion thresholds that we use in babies. Before 2019, there was only one randomized control trial, which was published by Maureen Andrew et al. From Ontario in Canada in 1993. And this trial used transfusion thresholds that we don't really use anymore. And we can see from what you told me already that we don't use transfusion thresholds of 150. And the aim of this study was to maintain platelet counts above 150 with transfusion to avoid IVH, severe IVH, and extension of IVH. So do we still transfuse platelets because we are afraid of IVHs and their consequences? Maureen Andrews' study showed us that there was no difference in IVH. And if anything, if you looked at the numbers very carefully, there was actually an increase in severe IVH when she was looking at her primary outcome. And so that is concerning. Kumar et al. Study that was published in 2019 that I've mentioned already actually showed, when they did statistical analysis with multivariate logistic regression, they showed that the cumulative volume of platelet transfusion was a risk factor for IVH, and it showed double the incidence of a grade 3 or 4 IVH in the group that was transfused and quadrupled the risk of any IVH. Now, what I would say about this study, it wasn't powered to assess IVH, and so it wasn't statistically significant. Kumar et al. Study was one of the 2 randomized control trials of platelet transfusion that came to our evidence base in 2019. We're not going to talk any more about it. I have mentioned it a couple of times. But it does note that there was an IVH rate in the liberal transfusion group of 40.9% compared to 9.1% in the restrictive group. Over 5 years ago, the results of this study, which was the PLANET-2 Matisse study, was published. It enrolled babies who were born at less than 34 weeks and compared transfusion at a platelet transfusion threshold of 50 compared to the intervention, which was a platelet transfusion threshold of 25. 660 babies took part in this study in 43 centres across 3 countries, the UK, the Netherlands, and Ireland. PLANET-2 showed a significant difference in the occurrence of the primary outcome, which was death or a major bleed, with death or major bleeding occurring in 26% of the babies transfused at a platelet transfusion count of 20, or at 50, sorry, I'm really confusing myself now, compared to 19% in the babies who were transfused at a platelet count of 25 or less. This was statistically significant. This curve shows that survival without major bleed was significantly lower in the high threshold group. As well as the primary outcome, we can also see that there was a difference in the proportion of babies who were diagnosed with bronchopulmonary dysplasia at 36 weeks in this group. Some neonatologists commented that they had concerns that the results of PLANET-2 might not be applicable to the smallest, sickest babies that we look after and the babies we are most worried about. But the PLANET-2 Matisse trial team did further analysis that showed that even the smallest and sickest babies benefited from this lower transfusion threshold. We can see here that the babies who are at the highest risk of bleeding, the smallest and sickest babies who had a baseline predicted risk of major bleeding or death that was greater than 24%, they benefited from this lower transfusion threshold. The lighter colours are the lower group and the darker colours are the higher group. We know that IVH and BPD are associated with worse neurodevelopmental outcomes, and so we knew that it was very important to complete the follow-up of the babies who took part in this trial, despite not having extra funding for it. Why? We know that despite significant progress in neonatal care over the past decades and improved survival in the babies we look after, extreme prematurity continues to be associated with long-term neurodevelopmental and health impairment, with a high risk of death and major brain injury at early gestations. There's also increased awareness that follow-up until the age of 2 years corrected, as probably a minimum, is essential in trials of neonatal interventions. The difference between neonates and adults is that babies survive for longer with the consequences of what we do to them in order to take care of them in the neonatal unit. These interventions may have implications for the child's development and their whole family for the rest of their lives. Recently enough, the 2 published red cell transfusion threshold studies have included neurodevelopmental outcome as their primary outcome. And we know that in the PLANET-2 Matisse study, more babies died or had major bleeding in the group that were transfused at the higher threshold. And we know that this risk was present irrespective of their baseline rate of bleeding or death. But we don't know if platelet transfusion thresholds have any impact on morbidity in the form of serious neurodevelopmental impairment or mortality after 28 days or respiratory outcomes. So in the PLANET-2 protocol, there was a predefined plan for the follow-up of these babies at 2 years. And very sensibly, as you'll see, they were very pragmatic outcomes defined. Substantial work has gone on since then in defining core outcomes in neonatology. And this paper from 2020 outlines a 3-round international Delphi survey and consensus meeting with input from parents of babies who were born preterm, adults who were born preterm, clinicians and researchers. Sepsis, necrotizing enterocolitis, and retinopathy of prematurity were already assessed in the PLANET-2 trial. And so what we looked at in the 2-year follow-up was survival, motor ability, cognitive ability, visual impairment, hearing impairment, and chronic lung disease. And because we were doing this follow-up nearly 10 years since the protocol was developed, it was vital that the outcomes that we were assessing were still relevant. And so we found this paper publication quite reassuring that it included the outcomes that we were looking at. Now, the follow-up of these babies at 2 years would have been almost easy if all of the children were followed up in the same centre, even the same centre they were born in, but that they also had complete formal neurodevelopmental assessment at 2 years. But this wasn't the case. Very substantial time and effort went into trying to locate all of the children who took part and their outcomes. If Bailey's or Griffith scores weren't available for the babies, or the children now, a Parker-Orr form was requested when they were 2. If there was no Parker-Orr form, we used the TORPG form, which is used to collect standard 2 years corrected outcomes across many UK units. If that form wasn't available, we contacted individual clinicians, and sometimes we contacted many individual clinicians to obtain not only locations on the babies and outcomes, but to obtain letters or reports on the children. This was, I suppose, both exhaustive and exhausting, but we did this because we felt that every baby's outcome mattered in this study. And this consort diagram shows the flow to the study, through the study. And again, I'm not really sure it captures all of the work that went into getting these outcomes, because we wanted the results of this study to be applicable to as many babies as possible. And so all of the hard work at finding how the outcomes on as many children as we could meant that of the 653 babies in the original cohort that required follow-up, we have an outcome on 601 of these children, which means that we achieved 92% follow-up. We can see the primary outcome of the 2-year follow-up here, that half of the children in the high threshold group died or had an unfavourable outcome compared to 39% of the children in the low threshold group. You can see here what were considered unfavourable neurodevelopmental outcomes. Cerebral palsy that impaired walking, global developmental delay, severe seizure disorder, severe hearing impairment that wasn't correctable, and not having any useful vision. These are severe outcomes. I know to some researchers, they may find these pragmatic outcomes quite crude, but they're not Bailey scores. They're very hard to look at statistically, but they're important to the clinicians who are looking after these children. And crucially, and most importantly, they're important to the children and their families. We didn't have the amount of standardized testing that other studies have very impressively managed, but it is much better to have pragmatic outcomes than no outcomes on these babies. Also important on this slide is the substantial difference in the proportion of children who required breathing or oxygen support at 2 years, with there being a much higher proportion of children in the high threshold group requiring oxygen or breathing support compared to the low threshold group. This is the first long-term outcome study ever published for preterm babies in an RCT of platelet transfusion. A higher platelet count threshold of 50 compared to 25 for prophylactic transfusion in preterm babies who were born at less than 34 weeks increased the rate of death or neurodevelopmental impairment at 2 years corrected. This gives us no evidence to support benefit for high prophylactic platelet transfusion and increasing evidence of harm persisting into childhood. We were very proud to publish the results of this follow-up in Archives of Disease in Childhood last year. It's also important to see if more recent evidence supports our results. This year, Patricia Davenport, so it was last year, Patricia Davenport, Martha Sola-Visner, Ravi Patel and their team performed an observational secondary analysis of data from the PEANUT trial to investigate the association between platelet transfusions and neurodevelopmental outcome using Bayley scores. And you can see that the primary outcome of death or severe neurodevelopmental outcome occurred in 46.5% of the babies exposed to a platelet transfusion and only 13.9% of the babies who didn't have a platelet transfusion. Also this year, Timothy Barr and Bob Christensen and the team in Intermountain Healthcare showed that sensitivity analysis suggested that transfusions may contribute, platelet transfusions and red cell transfusions may contribute to BPD, and they felt that modelling predicted that complying with restrictive guidelines could reduce transfusion rates and potentially moderate and severe BPD rates. But now we're going to ask, why could platelet transfusions contribute to death? Why would they contribute to worse neurodevelopmental outcomes? And why would they contribute to worse breathing outcomes? So again, Timothy Barr and Bob Christensen published a very interesting review of the babies in their units who were the highest users of platelet transfusions. And in the 8 babies that had more than 25 platelet transfusions each, 3 of them died, but every single baby had bronchopulmonary dysplasia, including the babies who were born at term. And all of the babies who survived had tracheostomy. Sorry, that's not highlighted, but these babies had very severe outcomes. A European group have published their protocol for systematic review and meta-analysis of the association between the development of BPD and platelet transfusion. And not just in humans, there has been very impressive work going on in little mice models looking at the inflammatory effects of platelet transfusion, particularly by Patricia Davenport and Martha Sola-Visner and their team. They showed the pro-inflammatory effects of platelet transfusion in neonatal mice, whether or not there was underlying inflammation. And they showed that the effects of platelet transfusion varied combined with different models of polymicrobial sepsis. Cassidy Delaney and her team based in Colorado, I think, suggested that platelet activation and release of platelet-derived factors could increase vascular tone, promote aberrant angiogenesis, and contribute to the development of pulmonary hypertension in neonates. We know from a huge amount of other research that inflammation in preterm babies is bad for their brains and their development. We know that brains have a huge amount of capillary beds, and we wonder, are brains more vulnerable to the negative effects of the inflammation that may come with platelet transfusions? We also know that bronchopulmonary dysplasia is multifactorial, but at its core, it is an inflammatory condition too. When inflammation damages the signaling in developing lungs, the later development of the lungs is compromised. Lungs have massive capillary beds in order to enable gas exchange. And is this again why they're so vulnerable to damage by inflammation? We did a pilot study to see if we'd be able to determine any changes in inflammatory proteins before and after platelet transfusion in the NICU. And so we did our study, which we called Script-Neo, and we were very happy to publish this in Pediatric Research in December 2023. We included 17 babies who required 26 platelet transfusions across 2 neonatal units, and we took dried blood spot samples before and after platelet transfusion. The samples were batch processed in Olink in Sweden using proximity extension assay technology, and we did the statistics in OR. Even when we corrected for multiple hypothesis testing, the levels of CD40, CXCL5, and TGF-beta were significantly increased post-transfusion. CD40 upregulates leukocyte adhesion molecules and is present in platelet transfusions in both the alpha granules and the platelet membranes. It has been associated with retinopathy of prematurity. CXCL5 is a chemokine that induces neutrophil chemotaxis, which is important in inflammation, and it's been associated with quite a lot of neonatal pathology. It's been associated with white matter injury in neonatal rats, with neck in neonatal and animal models of neck, and with BPD in neonatal mice. LAP TGF-beta is a growth factor that affects multiple regulatory pathways and inflammatory pathways, and it has been associated with BPD due to the formation of fibrosis, as well as the development of post-hemorrhagic hydrocephalus. So I'm going to ask the same question again. What do you think your platelet transfusion threshold should be in a baby that isn't actively bleeding? It's nice to see more adventurous targets as well. These are lower than on the first screen. Less than 1. 7. Yeah. So we can see that these numbers are less. They're not that different, but they are less than the first time I asked this question. So this showed a small amount of change between the two of them. This presentation was obviously made before I knew what people would answer on Slido, but can we change our practice? Patricia Davenport and the team in Boston used very robust quality improvement principles with their new restrictive guidelines after the publication of PLANET-2, and they reduced the number and proportion of non-indicated platelet transfusions, and very, very importantly noted there was no change in the occurrence of major bleeding. More work from Timothy Barr and Bob Christensen, and they looked to see if there was any impact from their implementation of a new restrictive guideline in their healthcare group. And they showed that although there wasn't a significant reduction in the number of babies receiving a platelet transfusion, they did show a reduction in the transfusion threshold and no increase in adverse outcomes. Alexandra Zebeda and the team in Montreal also published the results of their implementation of a new restrictive transfusion protocol at the start of last year. And they showed their changes decreased the proportion of platelet transfused babies by 46% and also importantly reduced donor exposure in transfused babies. So we asked earlier, is change possible? I think the parking machine in Dublin Airport, this is a couple of years ago, it does not cost €1 to park in Dublin Airport. It's a minimum of €3 for 15 minutes. But the machine does think the change is possible. But evidence on its own isn't enough to change how we work in NICU and how we make decisions. Doctors, not neonatologists in particular, I actually think we're probably not as overconfident as some other specialities, but doctors tend to think that we're better at making decisions than we actually are. Overconfidence bias can lead us to ignore information that's contradictory to what we think. And cognitive biases aren't just in medicine. Apparently 73% of drivers think they're better than average, but that doesn't make a lot of sense. There is also a massive lag in time in translating health research evidence to guidelines and practice. And they suggest that it can be up to 17 years. But even when guidelines and recommendations change, there can be a gap in the accepting of these changes by clinicians. This Spanish study of neonatologists in Europe showed that 42.2% of neonatologists, and this was published in 2011, the guidelines changed a good while before that. These neonatologists reported they would use intravenous sodium bicarb in babies with asphyxia during resuscitation. And they also showed that it was quite country dependent. Interestingly, we're here in Lisbon, and in 2011, as high as 68% of neonatologists in Portugal reported that they would use intravenous sodium bicarb, but less than 5% of neonatologists in Scandinavian countries. So everything we've discussed shows us not only is the evidence complex, but the change is probably even more complex. And fortunately, there is a huge amount of interest in making this change possible in neonatal transfusion. So before I leave this podium, I would like to thank my supervisor, Dr. Anna Curley, who unfortunately was unable to attend because it is school holidays in Ireland, and as well as all of the doctors, all of the nurses, all of the research teams, but most importantly, all of the babies and their families who took part in both the PLANET-2 study and the other research that we've done. It is an exciting time in neonatal transfusion research, and it's been really wonderful to not just see that lower transfusion thresholds are better in platelet transfusion, but they're also better in red cell transfusions. And so I suppose the same question one more time. I expect you'll probably see quite similar to the last slide. What's the lowest threshold you'd be comfortable with in a non-bleeding baby in NICU? And that slide was not there, so you don't have to answer it. Oh, that's great. Thank you very much.